Good morning, everyone. I am Bhaswati. I am pediatric clinical tutor here in Swansea Bay University. And welcome to the pediatric placements. Hope you had a great week so far. And I apologize for not being able to do this face-to-face because of my night shifts. So, today, our topic of discussion is pediatric history taking and examination. So, before we go into that, let's discuss a few things. So, the outcome of this whole tutorial is that you should be able to make a good planning for how to take a focus history, a good pediatric history, having an understanding of systemic examination in children, and also have a thought about how you want to adopt your approach according to the child's age and condition. So these are our learning outcomes from this tutorial and the key principles in pediatrics. Children are not small adults, and the history, which is often taken from the parents and the caregivers, they are very good at it usually. And also, it's worth involving the child in the conversation to get them on board would make your history taking process much more better. And also, the examination of the child would become easier because then they would build a rapport with you. And also, a lot of history taking and examination in children is a observation. So observe before you touch, and also, as I said earlier, building rapport and trust, just not with parents but with child as well. And the best way to do this is getting down to their level, either squat or kneel or try to sit, and try to be on the child's eye level, which makes them feel better and more, they take more confident on you. And also age appropriate communication, make all the instructions very easy for them to understand. That itself brings down a lot of anxiety and making them more comfortable would again make the whole process of examination and history taking easier. Right, so the components of pediatric history taking: introduction, as in any other medical history, introducing yourself, asking the parents to introduce or the caregivers. Sometimes it need not be parents, it could be grandparents or other caregivers. Also, if the child is verbal, having a chat with them as well and letting them speak for themselves. Then followed by the usual history taking process, which would be your history of presenting complaints, the past medical history, past surgical history, any medicines they are taking, any travel history, any history of any other medical conditions or medicines they are taking, and also the family and social history. The other parts which are very pediatric specific are your births, which would be B for birth and antenatal history, I for the immunization history, D for the developmental history, R for the red book, which says the growth and nutrition history, and the social and safeguarding history. These are the only five things, sorry, that is very pediatric specific, and followed by your examination. Okay, now let's practice before we go to the discussion of age components of history taking in detail. So, have a thought about how you would ask and what you would ask in the history for a 11-year-old girl, Lucy, came with abdominal pain and vomiting since 2 days. You can pause this video now and write your prepare your history questions which you would like to ask Lucy and her mom. Right, so history of presenting complaints. So there are two type of approach that we can do for history of presenting complaints. One is the ODCS and the other one is the Socrates. Do whichever feels comfortable to you, but I am going to discuss about ODCS approach. They are kind of similar to Socrates as well. Right, O stands for onset. So in the onset of the symptoms, you want to ask, for Lucy, it would be, when did the vomiting start? When did the pain start? How did it start? Did it start suddenly or did it started gradually worsening? And is there any pain anywhere else? So for her, it was a tummy pain that started 2 days ago, and then vomiting since one day, which gradually worsened. Then duration. So for how long Lucy had these, and was she okay before that? So mom says she was well before last 48 hours, and in the last 48 hours these things has happened. So duration is 2 days. And then about the character, so of each symptoms. So she has two symptoms here: vomiting and abdominal pain. So vomiting, it's non-bilious, non-bloody vomiting, not related to food intake. And the tummy pain is more on the epigastric region, and then it has progressed down as in generalized tummy pain everywhere. She is not able to localize where the pain exactly is. So that would be your character of the symptoms. And then your also the course also comes in C. So frequency of vomiting, she says 4 to 5 times a day, randomly coming anytime, with nausea and vomiting. And then also the abdominal pain is more of a dull, crampy pain, which comes and goes. And there is nothing that makes it better or worse. And she's not able to localize it anywhere specific. Right, and then comes your severity and any other symptomic system, any other associations. So that's your S. So she says it's a it says a pain score of 6, between 1 to 10, with 1 being the lowest and 10 being the worst pain. She says it is not relieved by rest. It is not relieved by paracetamol or brufen she has tried at home. And also associated features you can ask for: if there was anybody at home or school who was not well, did she have any contact history? And mom says no. And then asking about whether she was eating and drinking well before this last 48 hours. Mom says yes, but she says she prefers drinks, especially sugary drinks, more than food for the last few weeks. And she has been visiting toilet more often. So yeah, that is one thing to note down for. And then asking about whether she had any fever, any diarrhea, any constipation. Mom says no. And also asking if she has been well or any other symptoms. So she says she's a bit quite tired from the last couple of weeks, but mom says she did not get worried because Lucy has joined swimming lessons a month ago. So mom thinks the increased drinking and increased weeing and feeling more tired with a bit of losing weight is probably because from her swimming lessons that she has recently started, so she wasn't quite worried about it. Then mom says that she also smells quite nice since this morning, and she has been breathing not quite right. Mom can't explain what is going on, but because she wasn't breathing quite right, mom has brought her in. So that would complete your ODCS, or the history of presenting complaints. So based on this history of presenting complaints, the things that we can think of is whether she has acute gastroenteritis or she has DK with undiagnosed type 1 diabetes, or she has appendicitis, yeah, or she has a UTI. So yeah, these could be our differential based on the history given so far. Right. Then, going to past medical and surgical histories. So, um, asking whether she had similar episodes in the past. Mom says no. And then, did she have any other conditions for which she was admitted in hospital? Mom says no. And then, does she have any other chronic conditions that she has been diagnosed for which she is being treated? Mom says no. Is she on any kind of medications? Mom says no. Did her diet change? Mom says no. Any histories of any injuries or surgeries? Mom says no. Any history of any food allergies? Mom says no. And also worth asking if she has taken any new food anywhere, any travel history. Mom says no. Yeah, those will cover your past medical and surgical histories. And then comes the birth and the antenatal history, where so going way back from pregnancy, how did the pregnancy go? And mom says there was no concern, it was quite smooth. But worth asking whether she had any conditions like diabetes or hypertension or eclampsia. Was she on any kind of medication? Did she have any infection being diagnosed? Was she treated for anything? Was she on any medications for anything? Was she taking any regular medications like any vitamins or folic acid? Mom says, yeah, only folic acid and nothing else so far. And then also asking mom about if she had her antenatal scans regularly and were they all fine, and mom says yes, they were all fine. Then also talking about whether mom had any smoking habits, drinking habits, or any other drugs, and mom says no for that. And then asking during the delivery, were there any issues? Was Lucy term? Mom says yes, she was 40 weeks. Was she born vaginally or by section? Mom says vaginally. And did she have any issue after she was born? Did she need any oxygen support or feeding support, any special care unit support, or any NICU admissions? Mom says no. They were discharged on the same day. So the antenatal and birth history are these things. And also worth asking her birth weight. Mom says it's 3.5 kg, which was fine. So, okay. Next, immunization history. Mom says she is up to date for all her immunizations. And also, if you're thinking in terms of any infective etiology, worth asking if she had any recent vaccination. And also, if sometimes they said no, they did not have any particular vaccine or they did not have any vaccines at all, worth asking if there was a reason for it. And yeah, finding out. And also sometimes it's worth telling them the advantages of vaccination. That's pretty much your immunization history. Yeah, but of course it's for the parents to decide whether they want the vaccinations or not. But yeah, worth if they ask, it's worth letting them know why their vaccinations are important. Right, then comes the developmental history. So, in the developmental history, it's up to 5 years or 6 years the parents can keep a track on, and then usually it's a very hard thing to keep a track on by the parents. And also, if it's a child below 5 years, worth asking how their developmental milestones have been in each domain, like When did they start walking? When did they start running, which is your gross motor? When did they start writing? Are they able to write? Which hand preference they have? So that comes part of your, or dressing themselves up comes as a part of your fine motor, and then social um, language and speech, which is more like, do they like to communicate with children and play with children of their age? Do they respond to words? How many words they can speak and things like that, if they are below 5 years. But above it, it's a bit hard thing to guess the developmental history. But worth asking, in Lucy's case, you would ask, were her all milestones achieved in the right time? And mom says, yeah, she was fine developmentally. She was doing all her milestones and reaching them appropriately. Right. And also a bit of observation, if it's a small child, how they're behaving, and if they're running around or they're playing with their toys or they're trying to speak, that would tell you a lot of developmental history as well. Which I said earlier, observation is one of the key tools in your history and examination. So this is one of it. Right. The next one is nutritional and growth history. So yeah, worth asking how they have been doing since birth. Were they needing any feeding support? Were they feeding quite well? How their growth chart was? They might not remember exact weights and growth chart, but if you can ask if there were any concerns, or if they have their red book, worth having a look in it and finding out how their growth has been. And also nutritional wise, yeah, asking what their daily diet looks like. For Lucy, and mom says for the past few weeks she has been taking more of sugary drinks, and she has been drinking them a lot. And she has been always on the leaner side, but looks a bit more lean. But mom was not concerned because she joined her swimming lessons, and that could be a part of it. So yeah, worth checking those part, because if you're thinking in terms of whether she has diabetes or some autoimmune disease in the background that's running, which has not been yet diagnosed. So in that case, worth looking for what kind of food they're eating, if they're having enough calorie intake, enough protein intake or not, because that itself would affect their growth and weight. So in case of Lucy, it was more like she was having a balanced diet, and with good amount of protein and carbohydrate and good calorie intake. And also, but the only alarming thing in the history was she was taking a lot of sugary drinks in the last few days and last few weeks, and she wasn't gaining weight much. She was getting more leaner, and she was going to toilet more often, which is an alarming sign that you want to keep in mind from the nutritional history. Right. Then comes the family and social history. So yeah, it's worth asking if there are any issues in the family, or anybody had similar kind of presentation recently or in the past. And mom might not say, sometimes if it's a very open question, then you can ask specific questions. Like if you're thinking in terms of diabetes, you would ask if anybody in the family has any diabetes. And also sometimes type 1 diabetes, which is an autoimmune disorder, runs with other autoimmune disorders as well, like thyroid issues or celiac disease. So worth asking uh, them, like, do anybody has in the family thyroid issues or celiac disease? And mom says yes, father has celiac disease, and he has been fine with control of in the diet. And yeah, that would give you an idea. Okay, there is a history of autoimmune disorder in the family. Right. There might not be sometimes, but worth asking specific questions based on what you think the differentials are so far. And then asking about the social history, which would also include your safeguarding history. So worth asking how many people along with Lucy, lives in the family, in the house. How is the housing conditions like? Does Lucy have siblings, and how do they share rooms? How is mom managing all the children? So mom would say she has two other kids, and Lucy's one of Lucy's siblings share room with her, and the other sibling, who is a bit older, has her own room. And mom also says that dad is mostly out at work. So worth asking, what does mom and dad do? So having an understanding of their social um, dynamics, the family dynamics, and how much support they have got. So asking how you're managing, do you have enough support at home? And yeah, Lucy's mom says, yeah, I have good support. The grandparents sometimes come and visit and help us out, and dad also helps out whenever he has time. So things like that, and the social history, just to explore whether there are any safeguarding concerns or not. Right. Okay. So, based on the history we have taken so far, this is Lucy, who is 11 years old. She is a healthy child, but has been losing weight, being more lethargic, having polydipsia and polyuria in the background from the last few weeks, and she has joined swimming 4 weeks ago. So, based on this history, we would think the differential as either she has an acute gastroenteritis, or she could be having a DK, undiagnosed type 1 diabetes, which has precipitated her DK because of her going for swimming lessons, which is a lot of energy driven. Sometimes infections can also precipitate a DKA in an undiagnosed type 1 diabetes. So yeah, probably for her, it could be the swimming lessons. And then also thinking of whether she has acute appendicitis, because those pains also can abruptly happen. And acute gastroenteritis because she came with tummy pain and vomiting, so that can be one more reason as well. So yeah, so now comes to the initial management. Let's have a look at A to E of Lucy. So A for airway. So airway, we need to look for if it's patent, if she is conscious enough to maintain her airway. And Lucy's GCS is around 14 or 15. She's a bit lethargic but responsive to you, which tells you that she is able to maintain her airway, but worth keeping her on recovery position or a head elevation, because she has been vomiting. And if she gets more drowsy, she might get an aspiration. So yeah, worth checking that. And then breathing, how is she breathing? So as mom said, she was actually breathing quite shallow and fast, which can be because of acidosis, which is called the acidotic or the Cosmos breathing. That might be the case. And worth checking her SATs. Her SATs were fine at that time. It was around 94 and above, so you wouldn't be worried about that. And then also thinking in terms of doing a gas, because her breathing doesn't look normal. It's quite shallow and fast. So you want to do a gas to see how bad is her acidosis, and it will also give you what's her pH, what's her bicarb, what's her PCO2, her glucose levels, and also worth doing a ketone along with the gas to see how her ketones are. And gas will also give you the lactate. So to differentiate between whether it's an infection or diabetes with a DKA. Then circulation. So in circulation, you again look for whether there is a low blood pressure, how's her heart rate, and also looking for cap refill. So she was a bit tachycardic. That could be because she might be dehydrated because of vomiting. and also looking for whether she had an issue with her blood pressure. Her blood pressure was okayish, it was holding up, and her cap refill was a bit borderline, which was in between 2 and 3 seconds, and ideally it should be less than 2 seconds, and ideally checking the cap refill centrally, like over the sternum would be the ideal place to look for cap refill. So if she's looking dehydrated, it's worth having a cannula in and start giving her some bolus. Bolus would be ideally 10 mL per kg of normal saline, and starting her on some maintenance fluids, depending on her glucose as well. If her glucose, which we are expecting it to be high, if it was high, then you would start with normal saline. But if it was quite low, if it was below 4 or so, then you would think of whether we need to give her some dextrose along with normal saline and as well. Right, and also in your gas, the potassium levels would be seen, so worth checking that and worth thinking about whether she needs some potassium in her maintenance fluid as well. Right, and then coming to disability, which would be doing her AFPU or the GCS score. You can do an AFPU score, which will give you the approximate GCS score initially, and then you can do a total GCS score after she has been stabilized. So her AFPU score was A, which is alert, and AFPU stands for A for alert, V for responding to words, P for responding to pain, and U for unresponsive. So that is a faster way of getting the GCS score, approximate GCS score. Yeah, right. And then also looking into her pupil, if they're equal and reactive, and also the next thing that you would look for, if there are any meningeal signs, like doing the Kernigs and the Kernigs and Bridgens case, to rule out if there are any factors of meningitis. And also the next one is exposure, where you look for any rashes in the whole body to rule out meningitis. And also mom was telling she has a fruity smell, so you can sometimes feel that fruity smell, that is acidotic breath, that comes with DKA. So worth observing that, and also checking her temperature, and also maintaining normothermia would be a part of E management. Right. So we have done the initial management of Lucy, and this probably looks like DKA. So worth escalating to your seniors. And also there's something called the BSPED guideline, where it says if you have all your parameters from the gas and you put them on the table, it will say how much insulin to start on. So that was another thing to consider, how much potassium to start on, and she needs a whole hourly monitoring till she starts getting better. That would be monitoring her blood ketones, blood glucose, her blood gas, and her neurological orbs, along with other orbs. Right. Right. I'm going to discuss, there are a lot of parts of examination in children. I'm going to speak about the most important 4 basic system examination. They are respiratory, cardiovascular, neurological, and GI. So let's start with respiratory. Right. So let's discuss around the case so that it becomes easy to discuss and understand what are the things we are thinking of, and we do as a part of examination. Right. So here we have 5-year-old Luke with complaints of cough, coryza, and fever for 3 days. He has come in with increased work of breathing since last 6 hours, and mom has tried some blue inhalers at home, which did not improve his symptoms, hence was brought to PAU. Right, and this is his background history. Known user on regular inhaler steroids since 1 year, with 2 episodes so far of viral induced V's, which was in the last 2 years. That's why he was started on the regular steroid inhalers. Mom has also asthma, which is well controlled with her inhalers and no other history of concern. Right. So have a think about, you can pause this video and have a think about what are the things you want to look for and what are the things you want to do as a part of your respiratory system examination. Right, let's go for respiratory system examination for this child who is 5-year-old. So the preparation would be putting your sleeves above your elbow, washing your hand, introducing yourself, asking the parents to introduce themselves or the carers to introduce themselves, whoever is in the room along with the child, excuse me, and also asking the child to introduce themselves if they are verbal, and then looking at the child from head to toe. Try to be at the level of the child and have a look. If it's a smaller child, if it's a bigger child, they would prefer lying down. If it's a small child, they try to be comfortable in their parents' lap, which is also fine. Right, so in your general inspection, you would look for if the child is playful or if the child looks irritable or drowsy or comfortable, and then also looking for signs of respiratory distress, which would be your nasal flaring, grunting, any audible wheeze or stridor, then tracheal tug. In a young infant, it could be head bobbing, and then going down below, it could be subcostal or intercostal recessions, and looking for any signs of cyanosis on the face, like on the lips or on the earlobes, and then looking inside the mouth for any dryness in the oral mucosa that would give you a sign of dehydration, and then looking for sunken eyes and any other signs of allergic background or things like Dennis Morgan lines, which can happen in a child with allergic rhinitis in the background, and then do your step-by-step inspection, palpation, percussion, and auscultation of chest. So that would include, again, looking in the chest, how the shape of the chest is, and then looking from the front and the back, the expansion of the chest, how it looks like, and is there any tachypnea or is there any recessions, which we discussed earlier, and then palpation, which would be feeling for the tracheal position. It's very hard below 1 year, so avoid doing that in those infants, but in a bigger child you can still do it. And then also looking for vocal fremitus, which you try to do on the intercostal areas, and you can ask the child to say 999 or 99 or 123, whichever the child feels comfortable. Sometimes you can just talk to them or communicate with them while doing it. That will also give you the vocal fremitus, and you're comparing on both the sides. You want it to be equal and resonant on both the sides. If it's dull, probably there's a consolidation, and if it's hyperresonant, probably there's an air trapping, which can happen in asthma. And then you do percussion on all the intercostal spaces in the front and the back, and then you intercostal space in the front, and also and then listening to the lung and the heart sound while auscultating. So auscultating on both the sides and comparing both the sides in the front and in the back, and also in the axillary region too, and also above the clavicle on both the sides, to listen to all the areas of the lungs. And if there's any decreased breath sounds or any wheeze or any crackles, that's what you want to listen to. And then you want to do the other system examination as well, your ENT, to look for any source of infection there, and also listening to the heart as well. There is any murmur or any irregular heart rate while doing your chest examination. You can do the heart also, and then having a feel on the abdomen, which would be a brief examination. If there are any tenderness, any scar, any bruising, any engorged veins, there are things you would look for there as well. So that's your general physical examination. In case of look, it was wheeze, polyphonic wheeze bilaterally, and for look, that's why you would like to start with some nebulization and then look for his SATs, his heart rate. His SAS was around 90 to 93, and his target SAS should be 94 and above. So you would start him on some oxygen. That would be your 15 liters of oxygen through a NRM mask, and then you start him on some fluids. If he looks dehydrated, if he's not able to tolerate orally, then you give it through IV. And if it's a smaller child, you also can think of doing NG feeding, which can help them rehydrate. And also, if he was febrile, you would try to think of infective causes. So you would do some FBC, CRP, blood culture, UNEs to check everything is fine with him, and doing a viral throat swab or a bacterial throat swab, depending on whether he has high-grade fever or not, and any consolidation you're expecting or not on the chest. You would do a bacterial and viral swab to check if there's something going on, sub-infection is going on, and then also thinking whether you want to start them on antibiotics or not. If it's a viral, you wouldn't, but if you are highly suspecting of a bacterial infection and the child looks really unwell, you would think of starting an antibiotics, which could be oral or IV, depending on whether the child is well enough to take orally and whether the child is not very sick, or against IV. If they are not able to tolerate orally or they are very sick, then you would think of doing IV. And also whether to do chest x-ray or not. If you find that the child is not improving or worsening after initial management, you would think of doing an x-ray. Or if you have any consolidation anywhere or decreased breath sounds anywhere, you would think of doing an x-ray to rule that out. Of if there is any effusion or any pneumothorax or any consolidation, just to rule them out, you would do an x-ray. Right, okay. And then the things to think about for you are: what are the key signs of respiratory distress in children? How can you differentiate between asthma, wheeze from pneumonia? And when would you perform a chest x-ray in a wheezy child? And what does silent chest indicate? Have a thought about these, and you can always if you still think don't know the answer for them, we can discuss it at a later time. Right, let's go to the next examination. That would be your abdominal examination. So this is 13-year-old Ava with fever, pain abdomen since 3 days with worsening severity, has a background of chronic constipation and no other significant history. Pause the video, have a thought about how you want to approach, and then you can play the video back and see if you have missed anything in examining her. Right, again, your preparation is the same. Then going for general examination, you want to look for if there is any pallor, any icterus. Icterus, you look in the sclera of the eye, and how does the child look in general, happy, playful, or irritable, drowsy. And then looking at the lips and inside the mouth, if they look dry, is there cracked lips. So also looking for down if there are any rashes all over the body anywhere else, looking at the hands and fingers, if there are any clubbing, any swelling in the face, hands and fingers, then also looking how they're breathing, if they are having any difficulty in breathing and how the abdomen is, and if it's tender or if there's any distension, is there any rashes, are there any signs of rashes anywhere else, and any scars anywhere in the tummy, and that would be a general examination. And then you want to look for any scars anywhere else, including the tummy. Right, and then that would be your inspection. And then in palpation, you want to do superficial and deep palpation. So in palpation, you want to check for each of the 9 quadrant of the abdomen and palpate and see, and if she has any pain or not. Ava says she does have any pain on the right iliac fossa, and it doesn't radiate anywhere else. And then trying to do a deep palpation everywhere else to feel if all her other quadrants of the tummy, if there is any pain or tenderness. And also you palpate for the liver and spleen there, and you can also percuss to find any free fluids. And for her, there were no free fluids. And then you do auscultation to listen for bowel sounds. And yeah, so for Ava, the finding was she has right iliac fossa pain with fever and constipation in the background. Probably she has appendicitis. So for her, you would need to do some bloods, which would be your FBC, CRP, UNEs, LFT, and blood and urine culture. And also you need to do an ultrasound to rule out whether it's appendicitis, whether it's ovarian torsion, or whether there is any urine tract infection. And also other system, you would look for ENT for any focus of infection. You want to look, have a brief listen to the chest and the heart if there's any source of infection there, and then also look for the cervical, inguinal, and axillary lymph nodes because they would indicate infection. So your differential for her would be either it could be gastroenteritis, it could be mesenteric adenitis, which is common post-virally, then UTI, and also it could be constipation related pain. Then in the abdomen you could feel fecal mass. Your ultrasound will also confirm that. And then also doing if it's an ovarian cyst, torsion, or a mecal diverticulitis. So yeah, just to differentiate all this, if you do your examination history and the investigations, this would tell you one is the final result of the whole examination point. For her, it was appendicitis that was confirmed by her ultrasound. Sometimes if ultrasound is inconclusive, we do a CT abdomen to confirm it. So if a child came with this history and you have done all the examination and the investigations suggest appendicitis, the management plan will be giving IV fluids, some analgesia, starting antibiotics, and doing a surgical referral. Right, now the things to think about is how do you differentiate appendicitis from constipation in a chronic constipation? Why does appendicitis pain migrate from periumbilical to the right iliac fossa? It's because of the nerve that supplies the peritoneum. And then what are the risks of delayed diagnosis in pediatric appendicitis? And what signs would indicate need of urgent surgical intervention? That would be if there are signs of peritonitis, if you do an x-ray, there's a free gas or there's a free fluid collection and signs of peritoneal perforation. The child looks real toxic with the severe pain and guarding all over the abdomen and not just right iliac fossa. That would probably indicate a perforation and it's a surgical emergency. Right, next. Going for cardiovascular examination, having a thought about that. So, um, cardiovascular examination. A 12-week-old girl comes with complaints of fast breathing since last 2 to 3 weeks. She had been feeding well, but prefers bottle feed over diet breastfeeds and failing to gain weight. The background: term baby, birth weight of 3.5 kg, no other issues since birth, family history: two of her maternal cousins had murmurs when they were babies. They are now 4-year and 6-year old with no other issues, have been growing quite well. So, have a thought about it and then we can discuss about it in detail. You can pause the video here. Right. In general examination, so your preparation is the usual preparation. Then go for general inspection and examination from head to toe. So yeah, from the end of the bed, or you can say kneel down and have a look at the child. So looking at the child, does the child look tachypneic or tachycardic, alert or not, responsive or not? And then poor weight gain, does she look smaller than her age? And then is she distressed when she is lying flat? Looking at that would be important. Then looking for any cyanosis and pallor, uh, and then any dysmorphism on the face would be an important thing to look for. Then looking in the hands and the legs, checking for the caprafill, heart rate, respiratory rate, and the rhythm, the volume. Also looking for radial and radio-radial delay, and looking for femoral pulses, and then also listening to all the four uh, sides of the heart on your auscultation. So inspection, and then for palpation, you can feel for the apex beat, whether it's displaced or not. The apex beat can be a bit lateral to the mid-clavicular line on the fourth intercostal space in an infant, which later becomes moves more medially to the mid-clavicular line, and that is because as the size of the thymus decreases, there's a bit of shift, which is normal as they grow up. Then you feel for any trill, any heave, and also look for any precordial bulge, and also feel for the apex beat and look for the position. The normal position in this child should be a bit lateral to the mid-clavicular line on the fourth intercostal space, which was there for her. And then also in your palpation, you look for the liver and the spleen and the edges. In an infant, liver span could be a bit bigger. It could be 2 to 3 centimeter below the intercostal line, which is normal, but in a bigger child that should not be the case, right? And then in your percussion, there is usually no percussion done. It's rarely done in cardiovascular examination, but yeah, you can percuss for the abdomen for looking for the liver and spleen edges. And then on auscultation, you want to look for all the four sides of the heart, which is your upper left and right sternal edges and lower left and right sternal edges for your heart sounds. And for her, there was a pansystolic murmur on the lower left sternal border, which is very classic of VSD, and it can radiate to both sides. Right, and other system examination, having a listen to the chest and the lungs to see if she is tachypneic or she's breathing hard. Is there any crackle or wheeze there? And then crackles was suggestive of pulmonary congestion, which was not the case with her. And then abdomen, as I said earlier, to look for hepatomegaly, to feel for liver edges, and then Yeah, neurologically, if she's playful, active, responsive, probably she's fine. And then also looking for any rashes anywhere in the body to suggest if this was there's an infective cause, and pallor, of course, which we discussed earlier. Right, the investigations you want to do for her is the usual bloods, which would be a FBC, CRP, UNE. Along with that, you want to do an X-ray of the chest, and also you want to do an 2D echo and an ECG to find out what's going on and what is the reason of her murmur. Most common reason is VSD in children, and there could be a PDA or any other congenital malformations, which would be ruled out by the echo. And then, yeah, the general support would be like feeding support. If she's struggling to feed by herself, to do a NG feed for her, and also strict urine output monitoring, and also whether you need to discuss with your cardiology team to think about whether she would need some diuretics for her to avoid fluid overload, and monitoring weight and urine output and electrolytes would be really important management plan for her. So that would be it. And other system, you would always look for the other system, a brief examination of ENT, neurology we discussed, chest we discussed, and also looking for lymph nodes if there is any infection going in the background. Right, things to think about. What are the features that made you suspect a cardiac cause for AVA symptoms rather than a respiratory one? Thinking about that, then how would you differentiate heart failure from sepsis and bronchiolitis in an infant with tachypnea? What is the significance of hepatomegaly in an infant with suspected heart disease? That would actually signify volume overload and heart failure. And then how would you counsel the parents about feeding, growth monitoring, and prognosis? That would be a good thing to know about. What are the long-term complications if there is a large VSD which remains uncorrected? It can cause permanent changes to the pulmonary vasculature because of persistent high pressure, and it's called Eisenmenger syndrome, which is a non-repairable condition. So yeah, have a thought about these, and have a read about Eisenmenger syndrome. That would complete our cardiovascular examination. Right. Next, let's go to neurological examination. Right. A 12-year-old Alice brought in with complaints of headache, earfulness since 2 to 3 weeks, followed by difficulty walking, double vision since a week, with a background of no other significant history in an apparently healthy child. Have a thought about what are the things you want to do as a part of your neurological examination. Pause this video, write down what you want to do, and then we can discuss. Right, so again, your usual preparation. Then in a general examination, you want to look if she's looking drowsy, alert, or unwell. Then can she stand unaided by herself? How is she walking? And does she have any chronic illness signs like dehydration, any syndromic features on the face? Then looking for her vitals like her blood pressure, heart rate, respiratory rate, SATs, and then doing head-to-toe examination, looking for any scars, any rashes, any febrile signs and symptoms, and also then doing an cranial examination, which would be cranial of 1 to 12. So cranial of 1 is mostly asking about the history of any loss of smell sensation, and then your cranial nerve 2 would be more looking for the visual fields, a rough idea about a rough brief examination about her visual acuity and visual field, and have a fundoscopy done. And then if you find anything abnormal there, what referring her to the ophthalmology, and then doing her 3, 4, and 6 cranial nerves, which are usually done together, where you check for her eye movements, any drooping eyelids, any difficulty in closing eyes, and then nystagmus, which is rapid movement of eye and unable to fix on an object, and then looking for pupils, if they're dilated or constricted, equal or not, reacting to light or not, and then going for 5th and 7th nerve, where you want to see the facial symmetry, and then look for the facial sensations. Don't attempt to do the corneal reflex, it's not ideal. And then cranial nerve 8 would be your hearing, which would be your Weber's and Rennie's, and then also looking for balance, and if she is having any motion sickness, which would be a vertigo, which worsens when they lie down and gets better when they stand up. And then also looking for cranial nerve 9th and 10th, which would be a gap reflex. Do not perform that, but ask if she has any difficulty swallowing, or you can give her a glass of water and ask her to swallow, and you can have a look if she's doing it well. And then cranial nerve 11 and 12, which would be your shoulder shrug against resistance, and also tongue movements and any fasciculations in the tongues. You want to see those. That would be your part of cranial nerve examination. And then coming to cerebral examination, the first one would be your gait, which you can see in inspection itself, whether she is able to walk or not, with eyes open and closed both. And then diagnostics, where if she falls with her eyes open, the problem is with cerebellum. If she falls or sways with the eyes closed, that's probably a sensory. And then finger, nose, and heel shin test, which is the test of coordination, and also listening to how she speaks. If the speech is slurry or scanning speech, that would indicate something is going on. And then rapid alternating movements, which is called the diadochokinesia, and also the rebound test, where it's the finger nose test that you want to do to see if that's something she's able to do. So that would be a cerebellar function. And then your motor and sensory nerve examination, that would be all 4 limbs, tone, power, and then reflexes, both superficial and deep reflexes. Yeah, so superficial reflex would be, you can check your abdominal reflexes, and then deep tendon reflexes would be your triceps, biceps, supinator on the upper limb, and lower limb it would be knee jerk, ankle jerk, and your Babinski's. If Babinski is positive, below 2 years it's normal, but above that it's abnormal. And then also looking for sensation in all dermatomes. That would be part of your motor and sensory examination. Right, and then you would think about signs of raised intracranial pressure. That would be vomiting, headache worsening when they lie down and getting better when they stand up, reduced consciousness, there could be papilledema, and then bulging of fontanelle only in the infants whose anterior fontanelle is open, and then never miss Cushing's triad, which is a very clear sign of raised intracranial pressure, which would be bradycardia, hypertension, and irregular breathing. Right, and then looking for vital signs, and also doing some investigations. In her case, you would like to do few tests to rule out any infective causes. That would be your FBC, CRP, UNEs, LFT, urine and blood culture, and also if she had also making sure you do an ophthalmology and ENT referral for them to have a look at her ears and eyes, and then also thinking of imaging, either a CT or MRI, to rule out any space occupying lesions and take it from there. If she has any such lesions or any signs of space occupying lesion in the brain, then to discuss with the neurosurgical team urgently and to think of helping her to shrink the lesion by starting her on some steroids. And if you're thinking in terms of infective etiology, which would be ruled out if she has a fever or any rashes anywhere, then thinking of doing an IV antibiotics in such cases and doing a lumbar puncture if you're thinking in terms of meningitis or encephalitis. And yeah, of course, supportive treatment, like making sure that she's hydrated well and her pain is controlled well, would be a supportive part of the treatment. Right. And differentials for a presentation like this would be either neurological, which could be space occupying lesion, or an infection. It could be ENT infection spreading to the brain, or it could be a metabolic reason which you want to rule out. Right. Then the things to think about is, what is the significance of your symptoms in a child with neurological signs? When is it unsafe to perform lumbar puncture? That would be increased intracranial pressure or any cerebral edema. You don't want to do a lumbar puncture. That's why we do a CT before we are thinking of doing a lumbar puncture, to rule that out, because that would cause herniation of brain. How can raised intracranial pressure present? So I said, be mindful of GCS, Cushing's triad, and pupillary reflex. That itself gives you it's a very brief examination that you can do to rule out intracranial pressure signs. How would you manage if imaging showed a mass? That would be discussing with the neurosurgical team and thinking about starting her on some steroids to shrink the mass to help relieve the symptoms along with analgesia. And what are the red flags for urgent neurological or neurosurgical involvement? That would be your Cushing's triad, or any mass detected in MRI. That would be your urgent neurosurgical involvement that you need, or any stroke-like symptoms, anything like that. You want your neuro or neurosurgical team involved. Right. That's the end of all the history taking and examination. Hope you found it useful. Have a thought about that. And when we meet next week, you can ask me whatever questions you have regarding the same. I'm very happy to discuss them. And the take-home message would be, children's are not small adults again. Build a rapport, try to take the child on board, and then you will be getting a lot of history and a good examination, which would run smoother if the child gets on board. Then taking a good history gives you 70% of the diagnosis. Start with an observation, and then that gives you most of your findings. Examination should be systematic, but you need to be gentle and flexible. You can modify. It need not be strictly following all parts of examination as told. Integrate your findings and just don't list them. That would give you differentials to make your initial management plan, and never, never, never miss the red flags. Right. So that's the end of the session. Hope you enjoy your pediatric placement, and welcome once again to the pediatric placement, and hope to see you guys next week, and hope you enjoy the rest of your weekend. Right. Bye.